Hello, nursing fans. Today we are doing chapter 9 of Med-Surg, and it's on shock. We are on page 107 of the 6th edition of the Med-Surg book. Shock is defined as inadequate tissue perfusion. This means that there is not enough oxygen being delivered to meet the metabolic needs of the tissues. An oxygen deficit leads to tissue hypoxia and hypoperfusion of vital organs and cell death. It is important to identify patients at risk for shock and to monitor them for early signs and symptoms of shock. Timely treatment of shock reduces injury to organs. Prolonged shock leads to cell death and potential organ failure. Pathophysiology of shock. Tissue perfusion and blood pressure are maintained by three mechanisms. The first is adequate blood volume. The second is an effective cardiac pump. The third is effective blood vessels. The body is able to compensate for a problem in one mechanism. It does so by making changes in one or both of the other mechanisms. Shock occurs when the compensatory mechanisms fail to maintain the blood pressure, leading to poor tissue perfusion. Causes of shock include inadequate cardiac output caused by heart failure, hemorrhage, or a sudden decrease in peripheral vascular resistance due to anaphylaxis, a life-threatening allergic reaction. Sepsis, a life-threatening condition caused by the body's response to an infection resulting in organ dysfunction or neurologic alterations. Metabolic and hemodynamic changes in shock. When blood pressure falls, the sympathetic nervous system is activated. Compensatory mechanisms then begin. Epinephrine and norepinephrine are released from the adrenal medulla. This causes the heart to beat faster and stronger to increase cardiac output. Blood flow to the heart, brain, and liver is preserved by shunting blood from the intestines, kidneys, and skin. Epinephrine, cortisol, and glucagon raise blood glucose levels to increase the cell fuel. The renin-angiotensin-aldosterone system is stimulated by decreased cardiac output. This results in vasoconstriction and retention of sodium and water to maintain fluid balance. Respiratory rate increases to deliver more oxygen to the tissues. Together, these compensatory responses produce the classic signs and symptoms of the first stage of shock. Tachycardia, rapid heart rate. Tachypnea, rapid breathing. Oliguria, producing small amounts of urine. Restlessness, anxiety, pallor, and cool, clammy skin. If blood pressure and oxygen delivery remain inadequate, signs and symptoms of progressive and then irreversible shock are seen. Critical thinking. What is the cause and compensatory purpose for each of the classic signs of shock? Tachycardia, tachypnea, oliguria, pallor, and cool, clammy skin. So I'm now referring to the end of the chapter, which is on page 118 for the suggested answers. Tachycardia is caused by decreased cardiac output and reduced tissue oxygenation. Its purpose is to increase cardiac output and oxygen delivery with more heartbeats that pump blood out of the heart. Tachypnea is caused by decreased tissue oxygenation. Its purpose is to increase respirations so that more oxygen is available for delivery to tissues. Oliguria is caused by a reduced blood flow to the kidneys. Its purpose as a compensatory mechanism is to conserve as much fluid as possible to help maintain normal blood pressure. Pallor is caused by the reduced blood volume or flow. Peripheral vasoconstriction shunts blood from the skin to the vital organs. Cool, clammy skin is the result of decreased blood flow to the skin and the release of moisture, sweat from the skin. Sweating cools the body in anticipation of the fight or flight response, which generates body heat when it occurs. Learning tip. Tachycardia is a compensatory mechanism that is usually the first sign of shock. Sustained tachycardia is a signal that the patient's condition is changing. Older patients cannot tolerate tachycardia for very long. Report tachycardia to the registered nurse or healthcare provider. Consider the cause of the tachycardia. For example, a surgical patient who develops tachycardia may be hemorrhaging. Check for bleeding. Apply direct pressure to an area of hemorrhage. With internal hemorrhaging, there may not be visible bleeding. Vital sign changes may be the only sign. Take action. When cells are deprived of oxygen, their energy production is affected. It moves from efficient aerobic metabolism to a less efficient anaerobic metabolism. The energy needs of the cell can only be met by anaerobic metabolism for a brief time. If the oxygen deficiency is prolonged, the body's metabolic rate and temperature fall. Anaerobic metabolism produces lactate. Lactic acid, a byproduct of lactate buildup, accumulates. If the lactic acid is not cleared from the bloodstream, it causes acidosis, an acid-base imbalance. Acidosis, blood pH below 7.35, is one of the classic signs of shock. Critical thinking. Anaerobic metabolism. Why is anaerobic metabolism necessary and helpful if it produces the complication of metabolic acidosis? Well, anaerobic metabolism is the source of nutrition and energy for the cell that prevents cellular death when oxygen is not available. It is a short-term compensatory mechanism to help save the cell until oxygen becomes available again. Effect on organs and organ systems. Why does prolonged shock cause extensive damage to organs? It does so because inadequate blood flow results in tissue ischemia and injury throughout the body. Early in shock, blood is shunted away from the kidneys to save fluid. This helps preserve blood pressure to provide oxygen to vital organs. The kidneys can tolerate reduced blood flow for about 1 hour. The kidney cells then begin to die from a lack of oxygen and nutrients. Acute kidney injury can result. When the myocardium, the middle and muscle layer of heart wall, receives inadequate oxygenation, pumping action and cardiac output decreases and shock worsens. Acidosis, toxins released into the bloodstreams from ischemic tissues, or ischemia-induced arrhythmias, an abnormal heart rhythm, further reduce the pumping ability of the heart. If the brain is deprived of blood flow for more than 4 minutes, brain cells die from a lack of oxygen and glucose. Brain death can result from prolonged shock. Organs of the gastrointestinal system can be injured early in shock. Inadequate circulation to the intestines injures the mucosa. Paralytic ileus, intestine paralysis, can occur. If gastrointestinal bacteria or endotoxins move from the bowel into the circulation, toxemia can result. The liver can be injured by ischemia. If liver function is affected by this injury, elevated serum levels of ammonia, bilirubin, and liver enzymes, and decreased production of plasma proteins can occur. The immune system is weakened by shock, leaving the body vulnerable to infection. If the liver has been damaged, it cannot assist the immune system in providing defense. Table 9.1 shows the characteristics of the shock stages. So there's compensated, progressive, and irreversible are the three stages shown here. And compensated is when you're able to maintain blood pressure and perfusion. At that point, you're going to have tachycardia with bounding pulses. However, with normal blood pressure readings, your respirations will be at an increased rate and deep. And your temperature, it varies. The level of consciousness is most likely anxious, restless, irritable, alert, oriented, but with a sense of impending doom. And the skin and mucous membranes will be cool, clammy, and pale. The urine output and bowel sounds will be normal in this stage as the body is able to compensate for the changes. The progressive stage of shock is when compensatory mechanisms start to fail. And so you will have a tachycardia that's greater than 150 beats per minute. At that point, now the pulses will have become weak and thready. Most likely your systolic blood pressure is going to be below 90, and in hypertensive patients it will have dropped by 25% from their baseline. And you'll see a decreased diastolic blood pressure as well. Your respirations will be fast. You'll have tachypnea with crackles, and they will be shallow respirations. Your temperature will be decreased, although it can rise in septic shock during the progressive stage. The level of consciousness will typically be confusion and lethargy. Your skin and mucous membranes will be moist, cold, clammy, and pale. And the urine output will be decreasing to less than 20 milliliters per hour with decreasing bowel signs as well. Once you get to the irreversible stage of shock, there will be no response to treatment, and unfortunately, death is imminent. At that point, the heart rate will be slowing. There won't be any more pulses. The systolic will be below 60, and the diastolic will be decreasing possibly to zero. You will have shallow, irregular, slowing respirations, decreasing body temperature, and the patient at that point will likely be unconscious and comatose. They will be cyanotic, mottled, cold, and clammy, and their urine output will be as low as 15 milliliters per hour, or even decreasing until there is no longer any more urine output. So let's take a look at some of the complications from shock. Acute respiratory distress syndrome, ARDS, disseminated intravascular coagulation, DIC, and multiple organ dysfunction syndrome, MODS, are three critical conditions that can follow prolonged shock. MODS is a major cause of death following shock. When an organ has inadequate perfusion, it fails, and this then contributes to the failure of other organs. Learning tip: To understand what disseminated intravascular coagulation means, define each of the words. So disseminated means something that is scattered or widespread. Intravascular would be inside the vessel or vascular. Coagulation means clotting. Put together, these definitions tell you that DIC is scattered, widespread clotting inside the vessel. Hemorrhage does not seem likely when there is a clotting problem, but when many clots form throughout the body in response to stressors, few clotting factors remain available to form clots that are needed to prevent hemorrhage. As a result, hemorrhage is a risk in DIC. Classification of shock. The 4 types of shock are classified by their cardiovascular characteristics. So, hypovolemic shock is caused by a decrease in the circulating blood volume. Cardiogenic shock is caused by cardiac pump or heart failure. Obstructive shock is caused by a blockage of blood flow in the cardiovascular circuit outside the heart. And distributive shock is caused by excessive dilation of the venules and arterioles. The classic sign in all forms of shock is a decrease in blood pressure below the level needed to provide sufficient blood flow to the tissues for adequate oxygenation. Hypovolemic shock. Hypovolemic shock can be caused by dehydration, internal or external hemorrhage, fluid loss from burns, vomiting or diarrhea, or loss of intravascular fluid into the interstitial space from sepsis or trauma, which is physical injury caused by an external force. Heat exhaustion or heat stroke can also cause hypovolemic shock from excessive water loss through sweating. Signs and symptoms include restlessness, pale, cool, clammy skin, tachycardia, tachypnea, flat, non-distended peripheral veins, decreased jugular vein circumference, decreased urine output, and altered mental status. The body is usually able to compensate for blood loss of less than 15% or 750 milliliters. Tachycardia may be the only symptom. At 20 to 25% of blood loss, tachycardia and mild to moderate hypotension are present. With a loss of 40% or greater, like 2 milliliters or 2 liters, all signs and symptoms of shock are present. Volume loss alone might not be the contributing factor to hypovolemic shock. The patient's age, health status, and the time frame for fluid loss can also be factors. Okay, we're on page 110, table 9.2, the effect of shock on organs and organ systems. So for the lungs, the effect is an acute respiratory failure and or acute respiratory distress syndrome, also called ARDS. The effect on the renal system is renal insufficiency, acute kidney injury, arrhythmia, and then for the heart, the effect is arrhythmias, could be myocardial infarction, myocardial ischemia. The effect on the liver is a decreased production of plasma proteins, impaired clotting, elevated serum levels of ammonia, bilirubin, and liver enzymes. The effect on the immune system is a depletion of defense components. And in the gastrointestinal system, the effect is an absorption of endotoxins and bacteria. There's mucosal injury, pancreatitis, and possibly a paralytic ileus. The central nervous system undergoes ischemic damage, necrosis, and brain death. Nursing care tip. The Trendelenburg position, in which the body is supine with the feet raised higher than the head, was formerly used to increase cardiac output in hypovolemic shock. However, research has shown that it is not helpful in improving cardiac output for patients in shock and can have profound negative effects. Although you might still see this position being used, remember that the evidence-based practice produces the best patient outcomes, and we know that this is typically not the best thing to do for patients in shock. So cardiogenic shock. That occurs when the heart fails as a pump and decreases cardiac output. It requires immediate treatment to prevent death. Signs and symptoms are like those of hypovolemic shock. Pulmonary edema may occur. This differentiates cardiogenic shock from the other forms of shock. The main cause of cardiogenic shock is acute myocardial infarction or heart attack. Other causes are traumatic injury to the heart, myocarditis, which is an inflammation of the heart muscle, cardiomyopathy, heart valve defects, endocarditis, or arrhythmias. Obstructive shock. Obstructive shock occurs when there is a blockage of blood flow outside of the heart. Pericardial tamponade occurs when the pericardial sac fills with blood or fluid. This compresses the heart and limits its filling capacity. Tension pneumothorax compresses the heart because of an abnormal collection of air in the pleural space. Acute pulmonary hypertension is a sudden, abnormally elevated pressure in the pulmonary artery. It increases resistance for blood flowing out of the right side of the heart. All of these conditions decrease cardiac output. This can lead to shock. A pulmonary embolism or tumor blocking blood flow can also lead to shock. Signs and symptoms of obstructive shock are similar to those of hypovolemic shock, except that the jugular veins are usually distended. Distributive shock occurs when a peripheral vascular resistance is lost because of massive vasodilation. In hypovolemic shock, there is an actual loss of blood volume. But in distributive shock, there is no loss of fluid volume. Rather, the body's fluid distribution is altered within the body. There are three forms of distributive shock. There's anaphylactic, septic, and neurogenic. Anaphylactic shock is the most severe type of distributive shock. It occurs when the body has an extreme hypersensitivity reaction to an antigen or allergen. Death from anaphylactic shock can occur in minutes, but it is rare. Medical treatment must be sought immediately. Asthma or a delay in epinephrine injections can increase the risk of death. For safety, patients are taught allergen avoidance techniques. Anaphylaxis occurs most commonly from food allergies, such as shellfish or peanuts, insect stings, antibiotics, especially penicillin, anesthetics, contrast dye, and blood products. Symptoms specific to allergic reactions include urticaria, which is hives, pruritus, which is itching, wheezing, laryngeal edema, which is swelling of the larynx, Angioedema, or the airway, you don't want your airway to swell, so the laryngeal edema is very serious. Angioedema is edema of the skin, mucous membranes, or internal organs, all of which are very serious, and severe bronchospasm, which is narrowing of bronchi in the lungs. Signs and symptoms are similar to those of hypovolemic shock. They may also be seen. If conscious, patients can be extremely apprehensive and short of breath. Categories of shock. Hypovolemic shock. Causes for hypovolemic shock would include any severe loss of body fluid, including dehydration, internal or external hemorrhage, fluid loss from burns, vomiting, or diarrhea, or a loss of intravascular fluid into the interstitium. The signs and symptoms of hypovolemic shock are tachycardia, tachypnea, hypotension, cyanosis, oliguria, flat and non-distended peripheral veins, decreased jugular veins, and altered mental status. For cardiogenic shock, the causes could include myocardial infarction, a traumatic cardiac injury, cardiomyopathy, endocarditis, myocarditis, arrhythmias, and valvular disease. Signs and symptoms would include arrhythmias, labored respirations, hypotension, cyanosis, oliguria, altered mental status, possibly distended jugular and peripheral veins, and symptoms of heart failure. Obstructive shock would be any block to the cardiovascular flow, such as pericardial tamponade, tension pneumothorax, intrathoracic tumor, massive pulmonary embolus, or a large systemic embolus. The signs and symptoms of obstructive shock include tachycardia, tachypnea, hypotension, cyanosis, oliguria, which is reduced peeing, altered mental status, and possibly distended jugular veins. For distributive shock, you're going to look at causes that might include any condition causing a massive vasodilation of the peripheral circulation, including the subcategories of anaphylactic, septic, and neurogenic shock. Anaphylactic shock would be caused by a reaction to an allergen, such as an insect sting, medication, peanuts, antibiotic, anesthetic, contrast dye, or blood product. The signs and symptoms include tachycardia, tachypnea, wheezing, hypotension, cyanosis, oliguria, altered mental status, and you can have urticaria, pruritus, angioedema, laryngeal edema, and severe bronchospasm. And if the patient is conscious, they can be extremely apprehensive during anaphylactic shock. Septic shock is caused by a loss of vascular autoregulatory control and a loss of fluid into the interstitium caused by massive release of chemical mediators and endotoxins from pathogens. In the early phase or the warm phase of septic shock, you will see tachycardia, blood pressure, I don't know what that means. Urine output and capillary refill can be normal. Okay, so you may have normal blood pressure, urine output, and capillary refill. The skin may be warm and flushed. Fever is usually present, although temperature can be subnormal, and fever may be absent in older or in immunosuppressed people. And in the late or cold phase of septic shock, you'll see tachycardia, tachypnea, hypotension, oliguria, delayed capillary refill, cool clammy skin, and normal or subnormal temperature, as well as altered mental status. For neurogenic shock, which is definitely rare, it could be caused by a dysfunction or injury to the nervous system from a spinal cord injury, from general anesthesia, fever, could also be a metabolic disturbance or a brain injury. In the early phase, you'll have hypotension, altered mental status, bradycardia, so a slow heart rate, and warm, dry skin. However, in the late phase, definitely see tachycardia and the tachypnea, as well as the cool, clammy skin. Patient education. Patients who have severe allergies and a risk for anaphylaxis should have a prescribed epinephrine autoinjector. It is important to have the epinephrine autoinjector available at all times for rapid onset, life-threatening reactions. Medical treatment must be sought immediately after using the epinephrine. Septic shock is defined as life-threatening organ dysfunction caused by dysregulated host response to infection. Septic shock is defined as a subset of sepsis with circulatory and cellular/metabolic dysfunction associated with a higher risk of mortality. Septic shock has a higher risk of death. With septic shock, there is extreme hypoperfusion. Early diagnosis and rapid treatment of sepsis are vital to increasing survival rates. Septic cases have risen 5.7% per year from 2008 to 2012. However, mortality has decreased from 22.2% to 17.3%. The goal of the Surviving Sepsis campaign is to reduce the sepsis mortality rate. Factors that increase sepsis risk include being over the age of 65, having a chronic illness, having a weakened immune system, having severe burns, or being critically ill. Infections of the gastrointestinal tract, lungs, skin, and urinary tract are more commonly associated with sepsis. Bacteria that commonly cause sepsis are Escherichia coli, E. coli, Staphylococcus aureus, and Streptococcus. Evidence-based practice. Clinical question: what are the best ways to manage sepsis and septic shock? Evidence. The International Guidelines for Management of Sepsis and Septic Shock, 2016, provide updated evidence-based interventions. Nursing care-related interventions include the following: using a screening protocol for sepsis on acutely ill and high-risk patients, promptly obtain all ordered cultures, including 2 sets of blood cultures prior to antimicrobial therapy so that therapy is not delayed, administer ordered broad-spectrum IV antimicrobials, often initially with 2 different classes, within 1 hour of sepsis or septic shock diagnosis. Administer and monitor ordered IV fluids, 30 milliliters per kilogram of crystalloid fluid within the first 3 hours for hypotension or lactate equal to or more than 4 mmol per liter. Administer ordered vasopressors. Norepinephrine would be the first choice. And you'll also, of course, report your ordered lab results, such as the lactate level. Use ordered prone positioning for mechanically ventilated patients with sepsis-related acute respiratory distress syndrome. Maintain ordered glycemic control, so arterial blood may be more accurate for point-of-care testing. Provide ordered enteral nutrition. Early initiation is desirable, and assist with planning of care and the use of palliative care as appropriate. Implications for the nursing practice are careful screening for sepsis and promptly carrying out ordered interventions included in the 2016 guidelines are vital to increasing patient survival rates for sepsis and septic shock. Gerontological issues. Sepsis. The older adult population has less ability to fight infections, which places them at a higher risk for sepsis. In a study of California hospitalizations from 2000 to 2010, the sepsis rate for those aged 85 and over was about 30 times the rate for those under age 65. Neurogenic shock occurs due to nervous system injury or dysfunction that causes extensive dilation of peripheral blood vessels. Causes include spinal cord injury, general anesthesia, fever, metabolic disturbances, and brain contusions and concussions. Signs include hypotension and altered mental status, and during the early phases, bradycardia and warm, dry skin. As shock progresses, however, tachycardia and cool, clammy skin develops. Therapeutic measures for shock. Because of the life-threatening nature of shock, immediate medical treatment is needed. The nature of the shock must be determined, and interventions, including ventilatory and circulatory support, started. Life-threatening symptoms must be treated immediately. If septic shock is identified, then current sepsis care guidelines are followed. Medications that are used in shock are listed in Table 9.6. The order of interventions and testing is guided by the stability of the patient. Interventions include the following: 1. Airway management. 2. Breathing and respiratory support. 3. Cardiovascular support. 4. Maintenance of circulatory volume. 5. Control of bleeding if present. 6. Assessment of neurologic status. 7. Treatment of life-threatening injuries. And 8. Determination and treatment of the cause of the shock. Table 9.4. Assessment of the patient in shock. Signs and symptoms: tachycardia, tachypnea, hypotension, oliguria, cyanosis, and altered mental status. The laboratory tests will include arterial blood gases, blood chemistries, blood typing and cross-match, cardiac isoenzymes, complete blood count, partial thromboplastin time, prothrombin time, serum lactate, serum osmolarity, urinalysis. And for imaging, might include chest x-ray, a computed tomography or CT scan, which is a series of x-rays, echocardiogram, or a spinal x-ray. For monitoring, there will be an electrocardiogram, arterial pressure, and hemodynamic monitoring. The therapeutic measures for shock include airway management and respiratory support, such as oxygen, which could be delivered through nasal cannula, face mask, a partial non-rebreather mask, assisted ventilations with a bag valve mask, or a mechanical ventilator. We're looking to get the SpO2 over 95% and venous lactic acid less than 2.2 mmol per liter. For cardiovascular support, the measures include a vasopressor medication if fluid resuscitation is not effective, revascularization of the heart in cardiogenic shock via angioplasty with or without a stent, or fibrinolytic therapy. There's also antiarrhythmics and positive inotropes. Another therapeutic measure will be the adequate circulatory volume. So for that, there may be crystalloid fluids of 30 milliliter per kilogram within the first 3 hours for septic shock. You may use blood or blood products to increase the volume. Your target will be urine output greater than 30 milliliters per hour and a hemoglobin of greater than 10 grams per deciliter. For control of bleeding, if that's present, you'll have pressure dressings and possible surgical intervention. And for treatment of life-threatening injuries, again, there could be surgical intervention as well as numerous medications. And medications for types of shock would be for sepsis or septic shock, a broad spectrum antimicrobial within 1 hour of diagnosis. And for cardiogenic shock, there are diuretics, nitrates, inotropics, vasopressors. And for anaphylactic shock, you could do maybe epinephrine or diphenhydramine, which is also called Benadryl, and methylprednisolone, which is also called Solumedrol. Table 9.6 shows medications that are used for shock. So there are autonomic nervous system agents and alpha and beta adrenergic agents. So examples would be to strengthen myocardial contraction, to increase blood pressure and increase cardiac output. Epinephrine or adrenaline might be given, or dopamine, also called entropin. There's norepinephrine called Levophed, and phenylphedrine hydrochloride, which is neosynephrine. And the nursing indicators for these would be to correct hypovolemia before you give the medications, and then you will monitor vital signs often. And vasopressor use should include arterial blood pressure monitoring, as well as monitoring their ins and outs. Examples include to bronchodilate, you could use the epinephrine or adrenaline. That's the first drug given in anaphylactic shock. Just bear in mind that epinephrine doesn't work if they're on beta blockers. You'll need to use glucagon. Beta adrenergic agents increase the cardiac output in cardiogenic shock. So an example would be the dobutamine or the Dobutrix. So for that, you'll want to monitor vital signs often and monitor their ins and outs. An antihistamine will inhibit the histamine release. And an example is the diphenylhydramine, which is Benadryl. So again, you'll want to monitor vital signs because this may cause, and also know this may cause drowsiness. Anti-inflammatory will be given that to help control severe allergic reactions, and that would include the methylprednisolone, which is also called Solumedrol. or hydrocortisone called Solucordac, or dexamethasone called Decadron. So you'll just need to be sure to monitor the patient for signs and symptoms of infection. Page 114, nursing process for the patient in shock. Data collection. Recognizing and reporting patients at risk for shock is vital for increased patient survival. Being vigilant and screening patients for sepsis is important. Early detection and prevention of shock in patients at risk for shock are the desired goals. Rapid response teams can be helpful in providing quick assessment and care of patients at risk of developing shock. For the patient in shock, assessment must be carried out quickly and should always start with A, B, C, D: airway, breathing, circulation, and disability. Airway is checked for patency and opened as necessary. A compromised airway must be treated immediately with the head tilt / chin lift method, an oral or nasal airway, or an endotracheal intubation. Breathing is checked for rate, depth, and symmetry of chest movement. The patient is observed for use of accessory muscles. Lung sounds are auscultated. Wheezing can be present in the patient with anaphylactic shock. Crackles can be found in the patient with cardiogenic shock or in the patient who has received too much IV fluid. Circulation is checked with blood pressure measurement. A narrowing pulse pressure can be present before a drop in systolic pressure. This indicates a decrease in cardiac stroke volume and peripheral vasoconstriction. Peripheral pulses are palpated. Tachycardia is the first sign of shock. However, patients on medications that block the sympathetic nervous system response will not exhibit tachycardia. The pulse is assessed for quality. Commonly, it is weak and thready in a patient with shock. As shock progresses, the peripheral pulses become weaker or absent. A capillary refill greater than 3 seconds indicates inadequate circulation. However, it has been found to be an unreliable indicator of shock in adults, especially older adults. Other observations for circulation include distended neck veins, skin that is cool, pale, and diaphoretic or sweaty, clammy, the presence of cyanosis, a bluish color of skin, and mucous membranes from decreased oxygen in the blood, mucous membranes that are pale and dry, and thirst. Rapidly scan the entire body for evidence of bleeding or other injuries. Disability is determined by the patient's level of consciousness. A decrease in the level of consciousness indicates disability. This disability can range from lethargy to coma. Nursing care tip. There is usually a loss of peripheral pulses in the patient whose systolic blood pressure has dropped below 80. If you are able to palpate a radial pulse on your patient, the systolic blood pressure is usually at least 80. All 4 limbs are checked for circulation, sensation, and mobility. Remember as CSM, circulation, sensation, mobility. Bilateral responses are compared for equality. Circulation is assessed by palpating pulses for presence and quality. Sensation is determined by touching the patient's hands and feet and asking what the patient feels and if there is any numbness or tingling. Nursing care tip. Oh, wait a minute. Hold on. Wait a minute. Here we go. Let's skip here. Mobility is assessed by having the patient move all four limbs and wiggle the fingers and toes. Have the patient push his or her feet against your hands and squeeze both of your fingers to determine strength. A head-to-toe approach can follow the primary ABC assessment. The presence, severity, and location of pain or nausea and vomiting are noted. Body temperature is measured. Bowel sounds are auscultated to determine whether they are normal, absent, hyperactive, or hypoactive. With an indwelling urinary catheter, the color, rate, and amount of urine output are noted. Nursing care tip. To determine whether a patient is alert and oriented, ask his or her name, current place, and the date. If the patient correctly answers all three questions, he or she is, quote, alert and oriented times 3, person, place, time, or they've just memorized those answers since they get asked it every day in some places. Critical thinking. Mrs. Nabosny takes a beta blocker. What sign of shock do you understand will not be present? Tachycardia will not be present. Beta blockers block the cardiac response of the sympathetic nervous system activated in shock. Nursing diagnosis, planning, implementation, and evaluation. So remember, this is a shock summary here on this table, 9.7. The signs and symptoms of shock, typically tachycardia, tachypnea, hypotension, oliguria, altered mental state, and cyanosis due to poor tissue perfusion. So the diagnostic tests, what do you look for? Increased lactic acid, a decreased pH, which would indicate metabolic acidosis, possibly decreased hemoglobin with hemorrhage, and increased white blood cell count in sepsis. The therapeutic measures to consider would be oxygen, IV fluids, vasopressor medications, and treatment of the underlying cause of the shock. Complications include ARDS, DIC, or MODS. So ARDS is acute respiratory distress syndrome. DIC is disseminated intravascular coagulation. And MODS is multiple organ dysfunction syndrome. So the priority nursing diagnosis will be risk for ineffective tissue perfusion, either cerebral and or peripheral, decreased cardiac output. So the nursing care plan for the patient experiencing shock, for the nursing diagnosis, risk for ineffective tissue perfusion, cerebral, peripheral, related to hypovolemia or inadequate cardiac output or changes in circulatory volume or inadequate vascular tone, possibly evidenced by altered level of consciousness, changes in skin color/temperature, tachycardia, reduced blood pressure, and decreased urine output. Expected outcome: the patient will demonstrate adequate tissue perfusion as evidenced by warm and dry skin, strong peripheral pulses, vital signs within normal parameters of baseline, breath sounds without adventitious sounds, and balanced intake and output. The patient will be alert and oriented to person, place, and time within a specified time frame. Evaluation of outcome. Is the patient's skin warm and dry? Are peripheral pulses present and strong? Are vital signs within the patient's normal range? Are lung sounds normal? Intake/output balanced? Edema absent? And pain/discomfort absent? Is the patient alert and oriented? Intervention. Maintain airway and provide oxygen as ordered. The rationale is this ensures adequate oxygenation and tissue perfusion. Evaluation. Is the SpO2 over 95%? Are skin and mucous membranes pink? Are respirations between 12 and 20 per minute? Are lung sounds clear? Another intervention will be to monitor vital signs. Changes in vital signs, which indicate a change in condition, can be detected early and treated promptly. So is the heart rate between 60 and 100 beats per minute? Is the heart rhythm regular? Are peripheral pulses strong? Is systolic blood pressure greater than 100 mmHg? And is the patient alert and oriented times 3? Another intervention is to monitor ins and outs, intake and output, because adequate intake needed to the rationale is for adequate intake needed to maintain the cardiac output, and urine output is an indicator of renal function. So is the urinary output greater than 30 liters per hour? Another intervention will be obviously provide adequate fluid intake. The rationale is that it maintains volume. For evaluation, are the mucous membranes moist? Is skin turgor less than 3 seconds? Maintain body temperature with warmed IV fluids, room temperature, and blankets. Recovery is aided by normal body temperature. So is the body temperature within normal limits? Provide a quiet, restful environment, and the rationale is because this conserves energy and lowers tissue oxygen demands. So is the patient resting comfortably without anxiety? Monitor for pain and provide pain relief measures. Pain increases tissue demands for blood and oxygen, so is the patient pain-free? For geriatric patients, change positions slowly. Age-related losses of cardiovascular reflexes can result in hypotension. Is systolic blood pressure greater than 100 millimeters Hg, mercury? Nursing diagnosis, decreased cardiac output related to reduced circulating blood volume, structural damage, or decreased myocardial contractility as evidenced by abnormal vital signs and irregular cardiac rhythm. Expected outcome, the patient will have adequate cardiac output as evidenced by vital signs and cardiac rhythm within normal limits over a specified time frame. Evaluation of outcome. Are blood pressure, heart rate, and cardiac rhythm within normal limits? Are nail beds and or skin pink? Is skin warm, dry, and intact? Intervention. Monitor heart rate and cardiac rhythm with electrocardiogram and report abnormalities. The rationale is that changes in heart rate and cardiac rhythm can be detected immediately and treated appropriately. So are the heart rate and rhythm normal? We will monitor skin/nail bed color, capillary refill, and peripheral pulses and report abnormalities. Inadequate perfusion is first evident in the skin/nail beds and peripheral pulses. What color and temperature are the skin/nail beds? Is capillary refill less than 3 seconds? Are peripheral pulses present? Give cardiovascular medications and oxygen as ordered. Cardiac function can be supported with medications. Supplemental oxygen increases oxygenation of heart and tissues. So, are heart rate and rhythm normal? Monitor skin for pressure injuries and implement prevention interventions when vasopressors are used. Vasopressors, e.g., norepinephrine and vasopressin, can cause unavoidable pressure injuries due to vasoconstriction. So, is the skin intact? Provide comfort measures to alleviate pain and anxiety and maintain a normal body temperature. Pain, anxiety, and cold increase tissue demands for oxygen, which increases the heart's workload to supply it. So, is the patient free of pain and anxiety? Is body temperature within normal limits? For geriatric patients, monitor perfusion by methods other than capillary refill, such as skin temperature, because capillary refill is frequently delayed in the older adult population. Blood flow warms the body. So, is the body temperature within normal limits? Nursing diagnosis deficient knowledge related to unfamiliar condition of shock as evidenced by verbalization of deficient knowledge, e.g., I don't understand what's happening to me. Expected outcome. The patient will explain shock and its treatment. Evaluation of outcome. Can the patient explain shock and how it is treated? Intervention. Identify patient's ability to learn and barriers to learning. So for learning, the patient must be stable and ready to learn. Evaluation. Is the patient alert and stable? Does the patient indicate a willingness to learn? Intervention. Provide patient-centered information on shock and treatment. Giving individualized information on topics meets patients' need for understanding. Can patient explain shock and the purpose of treatment that the patient is receiving? Allow time for questions and clarification. The rationale is that clarification ensures accurate information is learned. Does the patient state accurate information? For geriatric patients, it will be important to involve family/caregivers in teaching. And the rationale is that family/caregivers can reinforce the education provided. Do family/caregivers verbalize understanding of the material presented? For geriatrics, you will also want to speak slowly and clearly in a low tone or pitch. Older adults have difficulty hearing high-pitched tones. Does patient acknowledge being spoken to? Provide materials in large print for geriatric patients. Visual changes that accompany aging can require a patient to need larger print materials. Can the patient restate and/or read aloud information that has been given? Critical thinking. Mr. Hall, who is 58 years old, had an acute myocardial infarction 2 days ago. He reports chest pain rated 10 out of 10 on the pain rating scale and difficulty breathing. His blood pressure is 96/40, pulse 110, respiration rate 22, and his blood oxygen saturation is 89%. Crackles are heard on auscultation of lung sounds or breath sounds. The electrocardiogram shows an irregular and rapid heartbeat. He is restless and apprehensive. So, name 3 priorities for Mr. Hall's nursing care. Number 1, nursing priorities for Mr. Hall include adequate tissue perfusion, relief of chest pain and anxiety, and stabilization of cardiac rhythm and vital signs. Number 2, with which members of the healthcare team does the nurse anticipate collaborating? the healthcare provider, and case manager. Number 3, are IV fluids appropriate for Mr. Hall now? 3, no, because Mr. Hall's lung sounds reveal crackles indicating fluid in the lungs. He should not be given IV fluids. He already has too much fluid within his body for his heart to handle, and giving him more IV fluids could be life-threatening. He should have an IV access for IV medications as needed. What signs and symptoms indicate Mr. Hall is in cardiogenic shock? Well, the signs of cardiogenic shock include a decreased blood pressure, increased heart and respiratory rates, cyanosis, decreased urine output, cool, pale nail beds and or skin, and decreased mental status. Critical thinking. Mrs. Neal, age 45, arrived at the emergency department in severe hypovolemic shock. She sustained several bleeding wounds in a motor vehicle accident. Her shock is resolving after receiving several transfusions and surgical repair of her injuries. She has just been admitted to your surgical unit for post-operative care. What post-operative data collection should be done first? Well, data collection for respiratory and cardiovascular status, inspection of surgical wounds for bleeding, and noting mental status and the need for pain relief should be performed first. Number 2, how can patient-centered care be promoted during treatment? Develop a pain management plan to meet Mrs. Neal's individualized needs. Identify her normal coping techniques to support their appropriate use. Provide explanations and teach as needed to keep the patient informed for decision making. Advocate for her individualized needs, such as nutritional needs. Number 3, what family-centered care can be provided to Mrs. Neal's family who is alarmed by her condition? Explain the cause of shock and all interventions, rationales, and desired outcomes. Keep the environment calm, provide for privacy, and answer all questions in a matter-of-fact and reassuring manner. Allow Mrs. Neal's family to visit. Number 4, what postoperative complications could develop in Mrs. Neal? Well, there could be unrelieved pain, bleeding, infection, and respiratory complications. Number 5, what nursing care documentation is appropriate for Mrs. Neal? Airway, rate, depth, regularity of respirations, breath sounds, SpO2, vital signs, cardiac rhythm, quality of pulses, skin color, blood pressure, body temperature, urine output, oral and IV intake, fluid balance. For pain, measures to relieve pain and evaluation of those measures. Dressings, drainage color, and amount of bowel sounds. Oh, an amount and then bowel sound, the presence of bowel sounds. Let's take a look at the review questions. Number 1, or actually there's some here, let's look at these, okay, in the slides. The nurse is reinforcing teaching to the family of a patient experiencing hypovolemic shock. Which of these would the nurse correctly state causes hypovolemic shock? 1, circulating blood volume is decreased. 2, the heart fails to pump blood. 3, there's a blockage of flow outside of the heart. 4, excessive dilation of blood vessels occurs. It's 1, circulating blood volume is decreased with hypovolemic shock. The next question, which action would be appropriate for the nurse to take for a patient with cardiogenic shock? 1, administer epinephrine as ordered. 2, give ordered antimicrobials within 1 hour. 3, question IV fluid orders. 4, provide ordered nutrition. And the answer is 3, to question the IV fluid orders because they have a fluid overload situation, so that's not appropriate. The nurse reinforces teaching to a patient with allergies that includes which of these? 1, sleep with the head of the bed elevated. 2, carry epinephrine auto-injector. 3, do ankle exercises hourly. And 4, change position slowly. And the answer for a patient with allergies is to number 2, carry an epinephrine auto-injector. Which of these would the nurse implement as the priority action for the patient with newly diagnosed septic shock? 1, obtain blood cultures before antibiotics. 2, give broad spectrum antibiotics within 1 hour of septic shock diagnosis. 3, monitor ordered IV fluids. And 4, provide ordered enteral nutrition. And in this case, the answer is 1, to obtain blood cultures before administering antibiotics. Now, in the next one, I've already highlighted the answers. For which of these interventions would the nurse implement for the patient experiencing shock? And we would definitely maintain the airway and oxygenation, definitely monitor vital signs, monitor intake and output, and relieve pain. Ambulating the patient is not going to be a thing, more than likely, and checking the capillary refill on an older adult might be a waste of time because they often have poor circulation. So let's look at the book now. For the review questions, the nurse is collecting data on a patient experiencing shock in the emergency department. The nurse would recognize the signs of compensation for shock as resulting from which of these mechanisms? 1, the peripheral nervous system depression. 2, central nervous system depression. 3, ding ding, sympathetic nervous system stimulation. Or 4, parasympathetic nervous system stimulation. And the answer is 3, sympathetic nervous system stimulation. Number 2, which of these findings during data collection would the nurse specifically anticipate in a patient experiencing anaphylactic shock? Select all that apply. Wheezing, I would say yes, they will be experiencing wheezing. Not too sure about hypertension or tachycardia or oliguria. Probably they will have urticaria and also bronchospasms. So that's, yeah, probably struggling with breathing. And those are the correct answers. Number 3, the nurse would recognize which of these conditions as the cause for decreased level of consciousness, which is commonly found in patients experiencing shock. Is it severe pain, endotoxins, cerebral edema, or cerebral hypoxia? And the answer is cerebral hypoxia. Number 4, the nurse is contributing to the plan of care for an older adult at risk of cardiogenic shock. Which of these interventions would the nurse include for the nursing diagnosis of deficient knowledge to aid the learning of this older patient about this condition? And so number 1, involve the family / caregivers in teaching. That's a brilliant idea. Let's do that. Number 2, use a high-pitched tone when speaking. Don't think so. 3, provide materials in large print. That sounds fantastic. So definitely want to do that if we can. reinforce the health promotion activities with the patient, speak slowly and clearly. So remember, with the deficient knowledge, that's not related to reinforcing health promotion activities, but speaking slowly and clearly is actually going to be a very important to resolving this lack of knowledge they have. So the answer is 1, 3, and 5. Number 5, the nurse is monitoring the patient experiencing shock who is being given crystalloid IV fluids. Which of these findings would indicate to the nurse that the treatment is effective? Would it be increased urine output? Would it be increased heart rate, clammy skin, or increased blood pressure? So in this case, the answer would be increased blood pressure would indicate that the treatment has been effective. The nurse is contributing to the plan of care for a patient experiencing shock. Which of the following nursing diagnosis is most appropriate to include in this plan of care? Is it 1, fatigue, 2, risk for ineffective tissue perfusion, cerebral or peripheral, 3, ineffective health maintenance, and 4, hopelessness? And the answer is 3, risk for ineffective tissue perfusion. Number 7, a patient who is hemorrhaging from a leg incision is restless and confused. The nurse applies pressure to the incision and calls for help. Which of the following treatments for shock would the nurse anticipate being ordered first? Would it be crystalloid IV fluids, oxygen, vasopressor medication, or 1 unit of packed red blood cells? In this case, it's going to be oxygen. Number 7, that's the answer is 2. Number 8, the nurse is assigned to the nursing care team caring for the following patients. Which patient would be the priority for the nurse to see first? Would it be a patient who was in an MVA, motor vehicle accident, with a blood pressure of 132/80, pulse 98, and respirations of 20? I don't think so, because that's really pretty normal. Number 2, a patient who has a migraine with blood pressure of 108/68, pulse of 84, and respirations of 16. Again, that's pretty normal. Number 3, a patient who slipped and fell with blood pressure of 112/74, pulse of 68, and respirations of 14. Sounds normal to me. Number 4, a patient who was 1 day post-op with blood pressure 88/58, pulse of 152, and respirations of 24. That is my priority. So the answer is number 4. Which of these objective data collection findings would indicate to the nurse that the therapeutic measures for a patient experiencing shock have been effective? Would it be a heart rate of 110? I don't think so. Blood oxygen levels of 89%? Nope. Systolic pressure of 118? That sounds really good. Or respiratory rate of 22 per minute? The only one that sounds good is number 3, the systolic blood pressure of 118. Number 10, the nurse is caring for a patient who is experiencing progressive shock. Place in correct order of occurrence the systolic blood pressure findings that the nurse obtained for this patient who progressed through the 3 stages of shock and is now in irreversible shock. Begin with compensated shock and use all options. So, in this case, the first one is going to be the highest one, which is 116. And then the next one is going to be this 86, and then just before imminent death, it's going to be 56 and probably dropping. So I hope that helps. Good luck on your studies. Thanks for joining us.